You're watching CTOM TV. Knowledge is power.
Okay, hello everybody. My name is Michelle Morand, and this is Alexander Rowland, and we are co-founders of Cancer Treatment Options and Management, a worldwide research and advocacy service that is independent and able to provide our patients and their oncologists with unbiased opinions about the latest and greatest in cancer care, really, and things that you can do to help yourself. Today, Alex is sharing with us information about gastric cancer. Apparently, there's a new study that you're quite enamored with.
Yes.
That is actually, in most cases, doubling, if not tripling, the survival of advanced gastric cancer patients. So tell us all about that, Alex.
Well, as you know, gastric cancer is a very dangerous cancer. It's the second most common malignancy worldwide, and it's the fourth most common cause of cancer mortality.
Wow.
And most cases don't get diagnosed until they're fairly advanced. In fact, 66% of patients present with advanced stage 4 disease at diagnosis.
Wow.
And in these patients, even with standard chemotherapy, the typical survival rate is about 7 to 10 months.
Oh, wow.
Yeah, so it's quite a bad one. You know,
Yeah.
people died of gastric cancer back in the 40s and 50s with a lot of regularity, just due to bad food. You know, heliobacterias, infections, parasites, and so on. So on an international level, gastric cancer is a big killer, and we've needed to have solutions for it for a long time.
And what's happening now?
Well, a recent study called the Pangea study was able to sequence a bunch of patients with gastric cancer. And that's not an easy job to do, because to find patients that are stratified for a particular clinical trial with a drug is really hard. So what
You mean for targeted therapies?
For targeted therapies, yeah. So what they did was they actually sequenced the patients first and then accessed the drugs.
Right.
So they did it kind of a little differently as far as basket studies.
Smart, though.
Yeah, because they're able to access drugs for patients that only had, only 5% of the patients actually had a mutation biomarker for that specific drug. So normally you wouldn't be able to do a trial of that, because it would take you years to accumulate enough patients. They wouldn't survive that long. And you'd have to go through thousands of different patients to actually find, patients that had that particular biomarker when it's only at 5%.
Right.
So in this particular case, this trial was able to eke out those patients that only had small amounts. And also they use liquid biopsies. And that's important because, as we know, heterogeneity is a big factor with cancers. So you can start with a tumor marker in a primary, and then treat it. And then a few months later, or a few years later, depending on how long it lasts, that patient could present with a metastasis with a completely different set of molecular features and require a completely different targeted therapy. And so the only way to determine, how this is working, you can't realistically rebiopsy someone every time. So the best way is through liquid biopsies. And this trial incorporated liquid biopsies. So basically they were doing a poor man's version of what we do. And they were focusing just on gastric cancers. So if you could cue the slide.
Sure.
I'll show you the results of this study, and I think it's quite impressive. So as you can see, they broke it down by the percentage of patients that had that marker.
Hang on a second here.
Out of the total.
I just want to make this a little bigger for people. There we go.
There we go. So as you can see, they broke it down by the markers and the percentage of patients that had that marker. So for PD-1 inhibitors, for the immune subtype of gastric cancer, only 6% of patients had that. But in those patients, when they gave them nivolumab, which is just a first-generation PD-1 inhibitor, these patients had a 1-year survival of over 60%. So that's fairly significant. And the median overall survival was not reached in this study. So already you're getting a great result. So for HER2 amplified patients, and there's a lot of newer, really beneficial HER2 drugs that we've discussed. We talked about one last week. the conjugate drugs and so on. In this particular case, 20% of patients had HER2 amplification, and they used, Herceptin, which is the oldest HER2 drug that we have, and probably the least effective out of all of the drugs. And look at the survival. They had a one-year survival of 73%, 25.8 months overall survival rate.
Whereas you said earlier, the standard is 7 to 10 months.
Yeah, I can only imagine what they would have gotten if it had to use some of the newer HER2 targeting drugs. And then for EGFR amplified, ABT 806, I'm not familiar with that drug. Only 10% of patients had this EGFR amplification, but they got a one-year survival rate of 75%.
Wow.
Typically what happens in EGFR amplified cancers is they do end up with EGFR mutations, and they require a second generation EGFR inhibitor, such as osimertinib or something. I'm not clear if they use that in this study, but I suspect if they did, they probably would have had a better survival than 14.9 months. But still, that's a lot better than the standard chemo. FGFR amplified patients, that was 25%, or sorry, 1%. I'm not familiar with this drug too, bemarituzumab, but they had a one-year survival rate of 100%, and the overall survival, or the median overall survival, was not reached. In phenomenal results. It's only 1% of patients, but it's been hard to get a trial with FGFR2 amplified patients. We have liquid biopsies for FGFR amplification, so we can determine based on that if a patient is responding or not. And then PI3K MAP kinase signaling, that was 25%. Ramucirumab, which is a drug that is approved for gastric cancer, but we're not sure who it's going to work in and who it's not going to work in. Now we know we have a better indication if people have mutations in this signaling pathway. They got a 63% one-year survival, a 15.1 month overall survival. I think that's great. EGFR expressing, they use the same drug. Not quite as good of a survival rate. Once again, I'm not sure exactly where they went with that particular study. Ones they didn't have biomarkers for, and I did read a bit about the study that they didn't have a drug for MET amplified disease. It's in the table, the heading. So they ignored MET amplified patients, which would have been a great target because we have some good drugs for that. They didn't treat them. I guess they couldn't access the drug. But they used ramucirumab in patients that they didn't have any targets for, and they still got 67% and 15.7% overall, 15.7 month overall survival. So across the subgroups, including the negative subgroups and the patients that didn't do as well as the other subgroups, they got an average of 66% one-year survival and a 16.4 month overall survival. So that is almost double the survival rate from standard chemotherapy just by using a targeted approach.
Right.
Hopefully this is going to increase tumor DNA sequencing acceptance across different cancer groups. I think we see this in all cases, regardless of the cancer subtype. But I think, this is really just bringing this point home. If you have cancer, get tumor DNA sequencing. End of story.
Right, because even in this cancer, which is, it's so prevalent, it's so hard to treat. Most of the time, people are stage 4 by the time they even get diagnosed. They have 7 to 10 months. Here, greatly increased. And oftentimes, don't you find that people have more than one mutation?
Oh yeah.
So that you can target one and then target another, and so this could even be far greater than is indicated here through this study in your experience.
Yes, exactly.
Yeah, that's very exciting. Very exciting.
Yes.
So if you know anybody who has advanced gastric cancer, make sure that they are petitioning for tumor DNA sequencing and that their doctor is exploring all the targeted therapy options for them, because that's giving people a lot of extra time. And if you have any questions about what you've seen here today, you can visit us at ctoam.com, send us an email, ask us your questions, and certainly arrange for a consultation with Alex. And thank you very much for watching.
Thank you for watching CTOM TV. Subscribe below and stay informed.